Dr. Worth from Boston to tell us about some of these really exciting NTRK fusion targeted therapy. Dr. Worth.
Thank you very much, and thank you everyone for the invitation to speak and the opportunity to talk about this. It is a really exciting small part of the field of advanced thyroid cancer, but a neat one, my disclosures here. So I think, as you know, the TCGA study was really beautiful and elegant and revealed that a significant portion of the papillary thyroid cancers that we treat harbor oncogenic drivers in most of the tumors that were analyzed. The largest, most common driver mutation was in BRAF, happens to be targetable, but there's a smaller percentage of papillary thyroid cancers and other thyroid cancers that harbor other potentially targetable driver alterations, and importantly, fusion alterations. So RET fusions are seen in 6% of the TCGA patient population. NTRK fusions in NTRK 1 or 3 were seen in only 2% of the patient population in this study. We know in children and young adults that those two fusions in particular are enriched in those patient populations. And really, if you think about it, papillary thyroid cancer is actually the poster child for fusion-driven cancers. This paper did an analysis of all of the solid tumors that have been evaluated in the TCGA. And as you can see here, thyroid cancer has the highest frequency of recurrent oncogenic kinase fusions. So when we're thinking about treating fusion-driven cancer, first and foremost in our mind, we should be thinking about thyroid cancer. So NTRK 1 and 3 are found to be altered in 2% of papillary thyroid cancers in adults and more in children. NTRK is in the neurotrophin family of receptor kinases. It's uncommonly expressed in multiple tissues during development, more so in the nervous system. TRK-A is involved in pain and thermoregulation. TRK-B is involved in movement, memory, mood, appetite, and body weight, and TRK-C in proprioception. You want to maybe think about these activities of these proteins when you're thinking about drugging. The TRK family of proteins. This probably doesn't show very well, but this receptor tyrosine kinase signals through the RAS-RAF-MAP kinase pathway as well as the PI3K mTOR pathway to lead to various signals into the nucleus, including for proliferation. So when TRK fusions occur, you see the ligand binding domain gets replaced by a very diverse list of 5' fusion partners that leads to constitutive activation of the protein intracytosolically. So this is just an example of an NTRK3 gene that gets fused with ETV6 gene. So there's a 5' end, and there's the TRK3 kinase end of the altered gene there. And what's important to in this diagram here is that it shows that with NTRK 1, 2, and 3, you see multiple different fusion partners. So when you're thinking about testing for these fusions in your patients, you have to have a test that can pick up this wide diversity of 5' fusion partners, not just one or two of them. So we see NTRK fusions across multiple different human tumors. In pediatrics, something that I had never heard of before, infantile fibrosarcoma, almost invariably harbors an NTRK fusion. And then I mentioned the papillary thyroid carcinomas in children. In adults, in the head and neck world, we see secretory carcinomas that arise in the salivary glands. They also almost invariably harbor NTRK fusions. NTRK fusions can also be seen in GI stromal tumors, and of course we see them in thyroid cancers. So, being a kinase, TRK is potentially druggable. And larotrectinib was the first drug that was designed to specifically inhibit it was designed to specifically inhibit TRK A, B, and C, all three of the protein products from NTRK 1, 2, and 3, and designed to be very specific for TRK and not hit the other kinases that we know and love that could cause off-target toxicity. So larotrectinib has been studied in several basket trials. Overall, in the paper that was published in the New England Journal of Medicine, there were 55 patients that were reported on who had enrolled in phase 1 and 2 trials that all harbored NTRK fusions. The most common tumor type in these 55 patients was salivary gland cancers, and then other soft tissue sarcomas, infantile fibrosarcomas, so these were infants and young children. And then the fourth most common tumor type in the New England Journal paper was thyroid cancer. The NTRK fusions were identified in the institutions or centrally, and various different assays were used, including next-generation sequencing and FISH. And NTRK fusions NTRK 3 were most common than NTRK 1, but also NTRK 2 fusions have been identified and were enrolled in the study. So in the larotrectinib 55 patient trial, this shows the waterfall plot here, color-coded by the different tumor types, shows that in all of these multiple tumor types, you're seeing a really beautiful response rate. Overall, the centrally reviewed response rate was 75%. The yellow bars represent the patients with thyroid cancer, and so you can see that the majority of the yellow bars here are coming below the 30%, minus 30% line. And another thing to note in the waterfall plot is that most of the bars drop well below the 30% line, so these are very deep responses, and you also see a significant complete response rate, centrally reviewed, that was 13%. That's a whopping complete response rate in oncology. This is a patient that was presented by Marcia Brose at ATA, and this is a patient who is a 33-year-old man with iodine refractory PTC. His disease harbored an ETV6 NTRK 3 fusion. He had been previously treated and had progressed on prior kinase therapy, and then in September of 2015, he was enrolled in the Laksa 195 or larotrectinib trial. So you can see here at baseline, he has a lot of disease in his lungs, and there's some cervical adenopathy as well. Actually, I have arrows and circles for you. And then at the first restaging at cycle 3, day 1, you can see a very nice partial response, both in the neck and in the lungs. And then by cycle 7, day 1, that lung nodule, or it might be a hilar node, I can't quite tell, has completely resolved. His lungs certainly look a lot cleaner. There's a bare mention of that cervical node there that had been quite large and necrotic at baseline. So this patient had a beautiful response. So this is a slide from Marcia's presentation at ATA that summarized the experience in the 7 patients with thyroid cancer that had been available at the time. Overall, in the thyroid cancer patients, there was an 86% response rate, and then the swimmer's plot here shows very nicely the duration of responses. Often on the x-axis, there might be 1 year out here, but this is actually well beyond 2 years down here on the x-axis. So very durable responses as well. And then these dots show the first time of partial response. So you see very early responses that are very durable in the majority of patients. It's also worth pointing out that one of these patients did actually have anaplastic thyroid cancer. This was this patient in the bottom bar. He or she did have a response. However, disease progression was experienced in that patient. There was a good update of the larotrectinib experience at ASCO just a month ago, and in this updated experience, 19% of the patients now treated with and reported on with larotrectinib have thyroid cancer. So it's now the second most common diagnosis in adults of patients treated with the drug. Overall, in the updated analysis, there's an overall response rate of 68% in all patients that have been treated and a 17% complete response rate. So in the ASCO update, the median follow-up was 17.5 months, and the median duration of response has not yet been reached. So, and then a median progression-free survival in all patients of 25.8 months. Now, the adverse events, I don't have detailed information for you. I'm sorry about that, but that might be because there's not too much to say. The drug is very well tolerated. The adverse events are mainly grade 1 and grade 2. Fatigue is the most common side effect. One of my patients on the study is a neurologist who does clinical research. He flies back and forth from Florida once a month for his study visits. And he tells me that he can do all of his work and everything, but he gets a little bit tired. That's the extent of his fatigue, and I think that that's pretty common. Dizziness has also been reported, not infrequently in patients. That tends to be fairly mild and actually seems to resolve in most patients over time. And then we've seen some nausea as well. But overall, larotrectinib, I think, is very well tolerated. So, of course, it was based on these really beautiful data that the FDA did approve larotrectinib just recently for solid tumors that harbor NTRK gene fusions. And I think it's important to note that this is the first small molecule or any oncology drug that's been approved not for a tumor type, but for a specific driver alteration, agnostic of the tissue diagnosis. And there's been activity seen across patient age, sex, anatomic and histologic cancer types, and as well as activity has been seen in all of the different NTRK 1, 2, and 3, as well as the fusion partners that have been described to date. And now larotrectinib is incorporated into the NCCN guidelines for thyroid cancer for NTRK-driven disease. It's not right to talk about NTRK fusion and thyroid cancer without talking about entrectinib. Entrectinib was designed a little bit differently than larotrectinib. Entrectinib was designed to inhibit not just TRK A, B, and C, but also ROS1 and ALK, which are important fusion alterations seen in non-small cell lung cancer. So there have been 3 studies that have been open worldwide evaluating entrectinib in patients with tumors that harbor all 3 of these various alterations. This Star Trek design is one of those 3. One of the important things about this is that the Star Trek approach, as well as the larotrectinib and Laksa approach, has been to make available to any patient who might be appropriate for the study to have molecular diagnostics available to them to see if their tumor does harbor NTRK fusions. So at ESMO this past year, the updated entrectinib results have been presented. And in this update, 54 patients with NTRK-positive tumors were presented. 9% of the patients had thyroid cancer in the entrectinib trial. And the thyroid cancer patients also happen to have the yellow bar. I'm not sure what it is about thyroid and yellow, but that happens to be the case. Overall, with entrectinib, there was a 57.4% response rate with a duration of response of 10.4 months, and a very similar side effect profile with the adverse events being mostly grade 1 and grade 2. So at present, the FDA has granted priority review for entrectinib as treatment for adult and pediatric patients that have NTRK fusion tumors, as well as patients with ROS1 fusion non-small cell lung cancer. So what's next? We now have Laksa 195 available in clinical trial. So unfortunately, with these molecularly specific small molecules, we have to expect that resistance will develop over time. Acquired resistance really is kind of a class effect or class problem that we have to deal with. And we have indeed seen resistance to NTRK inhibitors emerge in patients. And what we're seeing primarily are alterations in the kinase solvent front, as well as the XDFG motif. Both of these, I'm sorry, I was probably not projecting too well, but the drug larotrectinib gets in through here to the kinase domain. This is the solvent front, and here's the XDFG motif. So there have been mutations that arise in patients there at one of those 2 locations, in patients on NTRK inhibitors, and Laksa 195 was designed to get into that kinase domain despite solvent front or XDFG mutations being present. So this is now a drug that's in study in the first in human phase 1 studies. So far, we've had updates at AACR presented. 29 patients were enrolled at that point, and there was so far with Laksa 195 a response rate of 34%. It does look like the adverse events with Laksa 195 might be a little bit more significant, particularly the neurotoxicity of the drug, unfortunately, seems to be a bit more to contend with. So hopefully for your patients that get put on larotrectinib, they will remain in response for a very long time, so you don't even have to go there. But it's good to know that Laksa 195 is now available. So to wrap things up, with a couple of minutes left, Dr. Tuttle, you're welcome. A majority of our patients with advanced thyroid cancer, whether they're DTC, MTC, or ATC patients, now will be found to have actionable mutations or gene alterations. So I think that we've gone beyond the proof of principle that targeting these specific alterations will work. The studies have been consistently positive. I think, when you're thinking about balancing efficacy and toxicity, this approach for molecularly specific therapy is, in my mind, a no-brainer. And I really think that the time is now to establish a new paradigm for genotype-phenotype-driven approaches for patients with advanced thyroid cancer. I do think that we have challenges ahead of us. How do we identify each and every one of these patients that harbor the alterations and match them up with the best drug or best clinical trial? But we're getting there. And so I would like to just say thank you very much. And also, thank you to our hosts in Rome. I have another slide here. So this is Mass General where I work. It's 200 years old, which in the US is really old. So it's really good to come to a part of the world where there are really, really, really old places that are really cool. Thank you.
Thank you, Lori. That's an exciting medicine, exciting targeted therapy, and very nicely presented.